Welcome back to the Deep Dive. Today, we're stepping into a complex and often critical area of vascular medicine, the world of diseases affecting the mesenteric arteries and veins.
That's right.
While individually may be rare in the general population, conditions like acute arterial blockages causing that excruciating pain out of proportion to findings, or the chronic debilitating weight loss of mesenteric ischemia, or even the challenging presentation of venous thrombosis. They all demand really precise diagnosis and management.
Absolutely. And for specialist clinicians like you listening, navigating the latest evidence to, optimize patient care is just vital.
And to guide us through this intricate landscape, we're focusing our deep dive today on a really foundational document in the field, the 2017 Clinical Practice Guidelines from the European Society for Vascular Surgery.
Yeah, this was quite a monumental undertaking. It meticulously synthesized the available scientific evidence and, importantly, complemented it with expert opinion to provide clear guidance on how to manage this whole spectrum of diseases.
It's truly impressive, the effort that goes into creating documents like this. The authors, they explicitly acknowledge the extensive work of the writing committees, the reviewers. And they specifically honor the profound contributions of Dr. Paula Durango, who tragically passed away during the guidelines development. Her scientific integrity is really embedded and honored in the completion of this work.
A very fitting tribute to her dedication to the field, definitely.
So here's our plan for today. We're going to systematically unpack this guideline, covering the whole range of mesenteric vascular disease it addresses.
Okay.
We'll start by understanding how these recommendations were actually formulated. The methodology, the grading system they used.
The groundwork.
Exactly. Then we'll move through the core clinical entities: acute arterial ischemia, chronic arterial ischemia, non-occlusive ischemia, mesenteric venous thrombosis, arterial aneurysms, and even isolated arterial dissection.
Covering all the bases.
For each one, we'll focus on the key diagnostic approaches, the roles of different imaging modalities, the core medical and interventional treatment strategies, both open and endovascular, the reported outcomes, and crucially, the strength of the evidence supporting the recommendations, indicated by their class and level grades. We'll make sure to call those out.
Good. And we'll also touch upon the important areas the authors identified for future research, which is always insightful.
Absolutely. Our mission really is to distill the most important knowledge nuggets, providing you with an evidence-based understanding directly from this expert source. So let's start with looking at how these guidelines were actually put together.
All right, let's unpack this guidelines foundation. So the European Society for Vascular Surgery, the ESVS, they developed these guidelines specifically to assist physicians, like yourself, in selecting the best management strategy for patients with diseases of the mesenteric arteries and veins. The guideline writing committee, which was comprised of experts in the field, based these recommendations on the scientific evidence available, but importantly, supplemented by expert opinion. The aim was to summarize and evaluate the best available evidence at that point in time.
And they're quite clear that these aren't meant to be sort of rigid rules for every single patient, are they?
Exactly. That's a key point. They explicitly state these recommendations are valid only at the time of publication because, the field evolves rapidly, technology changes.
Sure.
They also crucially emphasize that this guideline should never be seen as the legal standard of care in all patients. It's framed as a guiding principle.
Okay.
Care for any single patient must always depend on individual patient factors, things like symptom variability, comorbidities, age, activity level, and also the treatment setting, meaning the techniques and expertise available locally.
So it's really a framework to inform individualized care. How do they actually gather the evidence for this framework?
Well, they followed a pretty systematic methodology. A systematic literature search was conducted across major databases: Medline via PubMed, Embase, CINAHL, the Cochrane Library up to December 1st, 2015. Then they did a second search for papers published between 2015 and 2016 in August 2016.
Okay, pretty thorough.
Yeah, and they included articles in English, German, and French. They prioritized aggregated evidence, so multiple randomized trials, meta-analyses at the top of the pyramid, then single randomized controlled trials, then observational studies.
What do they exclude?
Generally, single case reports, animal studies, and in vitro studies were excluded from the primary evidence base. They focused on larger studies, say minimum 20 subjects per group if available, but if not, smaller studies were also included where high-level evidence was scarce. They also allowed for inclusion of really paramount articles published after the search cutoff or in other languages if deemed essential.
And how did they then translate all this gathered evidence into the specific recommendations we'll be discussing?
They used the European Society of Cardiology grading system. So for each recommendation, they assigned two things: a level of evidence, A, B, or C, and a class recommendation, class 1, 2A, 2B, or 3. This was based on weighing both the scientific evidence and the expert opinion of the committee.
Okay, can you quickly break down those levels, A, B, C?
Sure. Level A means the evidence comes from multiple randomized controlled trials or robust meta-analyses. That's the strongest level you can get.
Right.
Level B is from a single randomized trial or large, well-conducted, non-randomized study is still good evidence.
Okay.
And level C is based on expert opinion, smaller studies, retrospective studies, or case series, so a lower level of evidence, but sometimes it's all you have for rare conditions.
Got it. And the class 1, 2A, 2B, 3, that tells you how strong the recommendation actually is?
Correct. Class 1 means the treatment is recommended. There's good evidence or general agreement that it's beneficial, useful, effective. Basically, it should be done.
Okay.
Class 2 means the evidence or opinion is conflicting, or there's some divergence of opinion about usefulness or efficacy.
And the A and B differentiate within class 2.
Exactly. Class 2A means the weight of evidence or opinion is in favor of usefulness as efficacy. So the recommendation is that treatment should be considered.
Right.
Class 2B means the usefulness or efficacy is less well established, so the treatment may be considered. It's a weaker recommendation than 2A.
Okay, less certain.
And finally, class 3 means the treatment is not recommended. There's evidence or agreement that it's not useful or effective, and in some cases, potentially harmful. It should not be done.
Got it. So class 1 is a strong do it, class 2A is probably do it, 2B is maybe do it, and class 3 is don't do it. We'll definitely keep an eye out for those grades as we go through.
Exactly. It's a really helpful framework for understanding the strength behind each piece of guidance.
Okay, let's move on to defining the actual diseases covered. What's the scope of mesenteric vascular disease according to this guideline?
So the guidelines cover diseases affecting the mesenteric arteries, that's the coeliac artery, SEA, the superior mesenteric artery, SMA, and the inferior mesenteric artery, IMA.
The big three.
The big three, exactly. And also the mesenteric veins, the superior mesenteric vein, SMV, inferior mesenteric vein, IMV, portal vein, PV, and the splenic vein, SV. They do note that the SMA and its territory get mentioned about 5 times more often in the literature, reflecting its clinical importance.
And what's not covered?
Explicitly, diseases of the renal arteries are not covered in this document.
Okay. And how do they classify these conditions clinically? What are the buckets they use?
They use a few classification angles. First, by the presence or absence of symptoms. Second, by the clinical presentation, acute, chronic, or acute on chronic. And third, by the specific vessel involvement, which artery or vein, how many are involved, is there external compression, etc.
Okay, let's take those main presentations, starting with acute mesenteric ischemia, or AMI. What's the definition there?
AMI is defined as the abrupt cessation of mesenteric blood flow. This leads to symptoms that can vary from developing over minutes, like with an embolism, to hours, perhaps with atherothrombosis.
And the key symptom?
The cardinal symptom is severe abdominal pain, which can then progress, potentially quite rapidly, to bowel necrosis and peritonitis if not treated. The main causes they list are embolism, atherothrombosis, non-occlusive mesenteric ischemia, which they call NOMI, and dissection.
Okay, then there's chronic mesenteric ischemia, CMI.
Yes, CMI. Atherosclerosis is the predominant cause here. The symptoms are typically much more insidious. Think postprandial abdominal pain, often called abdominal angina.
Right, pain after eating.
Exactly. That leads to a fear of eating, which is called cytophobia, and then progressive, often significant weight loss and maybe some bowel dysfunction. And importantly, CMI often requires severe stenosis or occlusion of multiple mesenteric arteries, usually at least 2 out of the 3.
Why multiple?
Because of that rich collateral network between the vessels. We'll come back to that.
Okay, and acute on chronic, what's that?
That's basically an acute event, like a sudden occlusion or maybe a drop in perfusion happening in someone who already has underlying CMI, so they've got existing significant stenosis. This condition often progresses really rapidly to bowel infarction because the collateral reserve is already compromised.
You mentioned NOMI as a cause of AMI. Can you define NOMI again in this context?
Sure. NOMI, or non-occlusive mesenteric ischemia, is described as the ultimate consequence of circulatory failure. So during low flow states, think severe shock, sepsis, post-cardiac surgery blood gets redistributed away from the mesenteric circulation to protect vital organs like the brain, heart, and kidneys.
Wow, okay.
It's particularly prevalent in critically ill patients. The key feature is this severe intestinal ischemia caused by hypoperfusion, often combined with intense arterial spasm or vasoconstriction, despite the major mesenteric arteries themselves being patent or open.
Got it. What other conditions fall under the scope of these guidelines?
They also cover extrinsic compression of mesenteric vessels, for example, by the diaphragmatic crura, which is relevant in median arcuate ligament syndrome, or MALS.
MALS, okay.
Or compression by tumor invasion, especially from pancreatic cancer. They mention congenital malformations and strangulated hernias are not covered. Then there are mesenteric artery aneurysms, both true aneurysms, which are rare, and pseudoaneurysms, which are more common and often related to inflammation like pancreatitis, trauma, or interventions.
Right.
And finally, mesenteric venous thrombosis, or MVT. This is usually caused by thrombosis, often linked to intra-abdominal inflammation, malignancy, inherited or acquired thrombophilic disorders, trauma, or myeloproliferative neoplasms.
And what's excluded under MVT?
For these guidelines, MVT specifically refers to thrombosis of the mesenteric veins, which might be associated with splenic and portal vein thrombosis. They explicitly state they do not cover isolated hepatic vein thrombosis, that's Budd-Chiari syndrome, or isolated portal vein thrombosis if it's not associated with mesenteric ischemia, which is apparently rare, or aneurysms of the portal vein.
Okay, that clarifies the scope. Let's briefly touch on how common these conditions are, the epidemiology section.
Sure. The incidence rates vary quite a bit, depending on the specific condition and presentation. For AMI, it's estimated to account for maybe 1% of all patients presenting with an acute abdomen.
But higher in older patients.
Yes, the incidence increases exponentially. With age, it could be up to 10% in those over 70 years old. An autopsy study suggested an overall AMI incidence around 13 per 100,000 person years. Arterial thromboembolic occlusion seems to be the most common cause, maybe around 68% of AMI cases.
In CMI.
The incidence of CMI is likely underestimated, partly because there isn't a specific diagnostic code for it. It might reflect an increase in reinterventions versus a true prevalence increase, but it definitely develops slowly over months or years due to atherosclerosis. The prevalence of significant stenosis in at least one mesenteric artery can be surprisingly high in patients with known atherosclerosis elsewhere, maybe up to 15% or even higher in some series, although most are asymptomatic.
What about MVT prevalence?
MVT is estimated around 2 to 2.7 cases per 100,000 people. Again, probably underestimated because of the heterogeneous presentation and sometimes asymptomatic incidental findings on imaging. One study found incidental abdominal venous thrombosis in 1.74% of scans. Interestingly, portal vein thrombosis is found about 10 times more often than MVT at autopsy, often asymptomatic.
And aneurysms.
True mesenteric artery aneurysms are rare, prevalence cited as 0.1% to 2%. Most are asymptomatic at diagnosis, likely due to increased imaging use. Pseudoaneurysms related to inflammation or trauma are more common, but their exact prevalence isn't well defined.
Okay. Understanding the anatomy is obviously crucial here, particularly that collateral circulation you mentioned earlier.
Absolutely fundamental. You have the three main ventral branches off the aorta, the coeliac artery, CA, superior mesenteric artery, SMA, and inferior mesenteric artery, IMA. Their anatomy, especially CA, can be quite variable.
And the connections between them.
Yes, the collateral network is incredibly rich. There are the pancreatico-duodenal arcades, like the arc of Rio Branco and the arc of Buehler, connecting the CA and SMA territories. Then, between the SMA and IMA, you have the marginal artery of Drummond and the arc of Rieland, sometimes called the meandering mesenteric artery. The SMA itself ends as superior rectal arteries, which connect down to the internal iliac system via the middle rectal arteries.
Wow, so very interconnected.
Very. These anastomoses mean that, especially with slow obstruction like in CMI, each vessel territory can potentially supply the entire viscera if needed. It explains why you typically need disease in multiple vessels to get symptoms. However, there are watershed areas, like the Sudeck point at the rectosigmoid junction, which are more prone to ischemia, for example, during aortic surgery or low-flow states.
And at the microscopic level?
Down at the microscopic level, you have this dense submucosal capillary network supplying the villi and microvilli. These are highly metabolically active structures and very susceptible to low-flow conditions.
What about the venous side?
The venous drainage largely mirrors the arterial supply. SMV drains the small bowel and proximal colon. IMV drains the distal colon and rectum, and the splenic vein drains the spleen, stomach, pancreas. They all converge to form the portal vein. Normally, venous drainage doesn't limit flow, but if outflow resistance increases, say due to thrombosis or external compression, it significantly impacts hydrostatic pressure and fluid balance in the intestines, leading to edema and potentially venous ischemia.
Okay. A core principle in managing acute mesenteric ischemia is intestinal salvage. Can you elaborate on that?
Yes, the fundamental principle is preserving as much viable bowel as possible. While laparotomy for peritonitis is mandatory, mesenteric ischemia presents a unique situation. Historically, the approach was often diagnosis by laparotomy, resect the clearly necrotic bowel, and then maybe consider SIP and revascularization.
But that's changing.
Yes, with the advent of rapid diagnosis using CTA and the availability of endovascular techniques, the argument now, supported by these guidelines, is often to try and restore blood flow first before definitive bowel resection, if possible and safe.
Why the shift?
The idea is that restoring perfusion might salvage borderline ischemic bowel that would otherwise have been resected. It can make it easier to distinguish reversible from irreversible ischemia after flow is restored.
Makes sense. Where should these patients ideally be treated?
The guidelines suggest patients are best treated in centers with experience in both open and endovascular revascularization techniques. A hybrid operating room is beneficial, allowing for both angiography intervention and open surgery in one place, although the logistics in an acute emergency can still be challenging.
What about assessing bowel viability during surgery? You mentioned it's difficult.
Extremely difficult sometimes. Clinical judgment looking at color, peristalsis, bleeding from cut edges is stated as the preferred method during laparotomy, Rec 7 Class 2A Level C. However, ischemic bowel can look deceptively okay initially, or conversely, look quite bad but still recover. The guidelines strongly advocate for leaving any bowel with no obvious necrosis in place and reassessing its viability at a planned second-look laparotomy, typically 18 to 36 hours later.
So be prepared to go back.
Absolutely. A liberal use of second-look laparotomy is recommended because bowel resection is frequently needed at that second operation. And importantly, if extensive resection is needed, especially in the presence of peritonitis, primary anastomosis, joining the bowel ends back together, is not recommended in this emergency setting due to the very high risk of leakage.
It was done instead.
Damage control principles often apply. Resect the clearly gangrenous bowel, maybe use staplers to close the ends, leave the abdomen open or use a temporary closure method, and plan for repeat laparotomies to reassess viability and eventually restore continuity or create stomas later once the patient is more stable and the bowel is healthier.
What about the risk of short bowel syndrome?
That's a major concern after extensive small bowel resection. The intestine does have a remarkable capacity for adaptation over time, up to a year, with the remaining bowel becoming hypertrophic and increasing absorption. But patients may need parenteral nutrition, sometimes indefinitely. The length needed to potentially wean off parenteral nutrition is roughly estimated at 50 centimeters of small bowel with an intact ileocecal valve, or about 100 centimeters without it. The amount of remaining colon also significantly affects quality of life.
What's the outlook for patients needing long-term parenteral nutrition?
The guidelines mention that quality of life on home parenteral nutrition is considered moderate to good, and outcomes for intestinal transplantation are improving, making it a potential future option, especially for younger patients.
Okay, Section 1.7 of the source document highlights the patient's perspective, which must be incredibly challenging in these critical situations.
It's absolutely crucial, but you're right, it's very difficult in the context of AMI, where patients are often critically ill, perhaps intubated, and unable to participate in decisions. In those cases, discussions about risks, benefits, potential outcomes like short bowel syndrome or mortality often have to happen with relatives initially.
And later on?
Later, there might be an opportunity to discuss longer-term expectations, for instance. The source cites a 5-year survival rate after AMI of around 50%, though the reference is actually from an MVT paper. It highlights the severity and the implications of needing parenteral nutrition.
What about in less acute settings, like CMI or asymptomatic aneurysms?
There, the guidelines emphasize a 3-step process for shared decision-making. First, provide clear information about the condition, treatment options, risks, benefits, and importantly, the uncertainties. This is crucial in the elective setting.
Okay.
Second, clarify the individual patient's preferences and values. How do they weigh the potential benefits against the risks? Different people have different risk tolerances.
Makes sense.
And third, aim for shared decision-making, especially when there isn't one single best solution. The clinician provides the data, emphasizing the patient's perspective, to help the patient arrive at a decision that aligns with their goals. Referral to an experienced center might also be part of this discussion for complex cases.
They even suggest developing patient leaflets.
Yes, they suggest specialized centers could develop easily understandable leaflets explaining the risks, benefits, and harms, ideally reviewed by communication experts. It's about empowering patients as much as possible.
That lays really important groundwork. Let's dive into the specifics now, starting with the big one, acute mesenteric ischemia, AMI.
Okay, AMI. As we mentioned, acute thromboembolic occlusion primarily hits the SMA. Symptomatic acute occlusions of the CA or IMA causing actual intestinal infarction are rare because of those extensive collaterals, assuming the SMA is patent. Spontaneous dissection is covered in a later chapter, and traumatic occlusion isn't covered by these guidelines.
Got it. So focusing on SMA occlusion, how do patients with an embolic cause typically present?
A high index of suspicion is absolutely vital. Think about patients with a history of previous embolism, or known cardiac sources for emboli, the major one being atrial fibrillation.
AFib again?
Yes, but also valvular heart disease, a dilated left atrium, recent myocardial infarction, or ventricular dilatation with mural thrombus. The typical clinical triad for acute embolic SMA occlusion is classically described as 1. Severe abdominal pain with minimal findings on examination, that pain out of proportion to clinical signs.
Heard that phrase many times.
Right. 2. Bowel emptying, so vomiting or diarrhea early on. And 3. The presence of a source of embolus, most often atrial fibrillation.
But it's not always textbook.
No, this triad isn't consistently present, maybe in 80%, according to one study cited. Clinically, you might see phases. Phase 1 is that sudden onset of severe pain, potentially reversible. Phase 2, sometimes a temporary decrease in pain, which can be falsely reassuring. And Phase 3, increasing pain with clinical deterioration and peritonitis, indicating irreversible damage.
So the bottom line is,
every patient with atrial fibrillation and acute abdominal pain should be suspected of having an acute SMA embolism until proven otherwise. Finding synchronous ischemic symptoms elsewhere, like acute limb ischemia or stroke-itia, can also point towards synchronous embolism and aid the diagnosis.
where do these emboli usually lodge?
Typically, the embolus occludes the lumen completely and lodges distal to the origin of the SMA, often beyond the takeoff of the middle colic or inferior pancreatico-duodenal artery, usually in a relatively non-calcified arterial segment in the middle or distal mainstem.
Okay, that's embolism. What about thrombotic AMI, often acute on chronic, you said?
Yes, exactly. Here, the symptoms tend to develop more gradually, over hours to days. These patients usually have significant underlying atherosclerosis risk factors, history of coronary artery disease, peripheral vascular disease, maybe an abdominal aortic aneurysm.
And often pre-existing symptoms.
Very often. They frequently have a history of chronic symptoms. First, that abdominal angina, pseudophobia, weight loss, and then present with an acute worsening. This acute on chronic pain is typically less abrupt and maybe less severe initially compared to embolism. It might be more constant and less related to eating than their usual CMI pain.
Physical exam.
Findings depend on the duration and extent. Early on, minimal findings, maybe some abdominal distension. Later, signs of peritonitis develop. Interestingly, acute on chronic patients might have lost weight down to a normal level by the time they present acutely. The guidelines stress that patients diagnosed with advanced symptomatic CMI should really be considered for treatment subacutely because this transition to AMI is unpredictable and devastating.
Are there any reliable laboratory markers to help diagnose AMI quickly?
Unfortunately, the guidelines are quite clear. No plasma marker is accurate for diagnosis in the acute setting.
Not even lactate.
Lactate, or L-lactate, is often elevated late in the course when bowel infarction is already established. While it has high sensitivity eventually, maybe 91–100%, its specificity is low, around 42%. And crucially, studies show lactate levels are often normal early in AMI, in about half of patients in some recent reports. So it's considered a poor marker of early AMI. It's really more a marker of general deterioration, systemic hypoperfusion, and impending death. Serial measurements also have limited value in predicting the extent of ischemia.
What about D-dimer?
D-dimer is consistently reported as a highly sensitive early marker, meaning it's often elevated early on in AMI. However, its specificity is very low because many other conditions elevate D-dimer.
So its value is?
Its main value is as an exclusion test. A normal D-dimer level at presentation most probably excludes acute SMA occlusion, given its high sensitivity, around 95–100% reported in series, including MVT and NMI. So useful to rule it out, but not great to rule it in.
Any other markers mentioned?
They briefly mention intestinal fatty acid binding protein, IFABP, but state small studies need confirmation. Isomeric D-lactate sensitivity also appears low, so really no single marker is reliable for early diagnosis. Combining markers might improve things, especially negative predictive value, but it's not standard practice yet.
So if labs aren't helpful early on, imaging must be absolutely key.
Absolutely critical. Multi-detector computed tomography angiography CTA is the recommended imaging modality for suspected AMI. This is recommendation 3, a class 1 level B recommendation.
What kind of CTA protocol?
They recommend a triphasic CTA protocol with thin slices 1 millimeter or thinner if possible. This allows detection of mesenteric arterial occlusion and also evaluation of the bowel wall and veins.
What findings suggest embolism versus thrombosis on CTA?
For an embolus, you'd look for a filling defect, possibly surrounded by contrast, typically in a non-calcified segment in the middle or distal SMA. You might also see synchronous emboli elsewhere, other visceral arteries, limbs, brain. For thrombotic occlusion, you'd expect to see clots superimposed on a heavily calcified occlusive lesion, usually right at the origin of the SMA.
CTA shows the vessel problem before the bowel changes.
Yes. The vascular pathology typically precedes visible intestinal changes like wall thickening or pneumatosis. This highlights the importance of early imaging.
What if the patient has kidney problems? Contrast is risky, right?
It is, but the guidelines address this. Recommendation 4 is a Class 2B level C, stating that CTA is recommended even with impaired renal function or elevated creatinine. The rationale is that the need to make a life-saving diagnosis outweighs the risk of contrast-induced renal failure in this specific high-stakes situation. It may be considered.
That's a strong statement about its importance.
It really underscores how critical CTA is. They also make the point that if the clinical suspicion of AMI is not explicitly mentioned to the radiologist reading the scan, the condition is highly likely to be underdiagnosed or missed initially.
Communication is key.
Absolutely. Radiologist experience matters too. A second look at the imaging might sometimes detect overlooked findings, as diagnostic delay heavily impacts prognosis. They also mention that sometimes, even with a confirmed mesenteric artery occlusion on CT, if the patient has no clinical signs of peritonitis and no specific intestinal findings on the CT itself, the occlusion might actually be asymptomatic and could potentially be managed non-operatively, though this seems rare in the acute setting.
Okay, let's do a quick micro recap here. We've covered how the ESVS guidelines were developed, the types of mesenteric vascular disease, their prevalence, the crucial anatomy, including collaterals, and the principles of intestinal salvage and patient perspective. Focusing on AMI, we've detailed the different presentations of embolic versus thrombotic occlusion, the limitations of lab markers like D-dimer, good for ruling out, and lactate, often late, and the absolute necessity of prompt, high-quality CTA for diagnosis, even potentially accepting the risk of contrast nephropathy. Communicating suspicion is vital. Now, let's move into the treatment strategies outlined for AMI.
Right. So for treatment of acute superior mesenteric arterial occlusion, intestinal revascularization is necessary in most patients. Just resecting the bowel alone usually doesn't save the patient's life, unless maybe it's a very distal embolus with a widely open proximal artery, but infarction often involves multiple segments.
Fix the plumbing first.
That's the goal. Optimal treatment involves both open and endovascular surgical capabilities. As we said, ideally treated in a vascular center, possibly with a hybrid OR, though logistics are always a factor in emergencies. The preoperative evaluation needs to determine if peritonitis is present and what the likely type of occlusion is, embolic versus thrombotic.
What if the CTA shows gas in the bowel wall or portal vein? Is that game over?
Not necessarily. Intestinal wall gas or portomesenteric venous gas on CTA indicates severe, likely transmural ischemia, but it doesn't automatically mean the situation is futile if treatment is timely. Laparotomy is definitely indicated for peritonitis or suspected infarction unless the decision is made for palliative care.
And the goals of laparotomy?
To assess the extent and severity of the ischemia and also potentially check vessel patency, maybe needing perioperative angiography. Laparotomy is generally considered safer and quicker than laparoscopy for evaluating the viscera in this setting. Assessing viability remains difficult, as we discussed.
And the timing revascularization before resection?
Yes, the guideline strongly prefers revascularization before any bowel surgery, if feasible. That's recommendation 5, class 1, level C.
Even if some bowel looks clearly dead?
Yes, even with limited necrotic bowel identified visually, the idea is restoring flow might save threatened bowel segments and makes it easier to differentiate reversible from irreversible ischemia later.
What if the initial laparotomy happens at a hospital without vascular surgery capabilities?
The recommendation is resect the clearly necrotic bowel without attempting reconstruction or anastomosis, close the abdomen temporarily, 4G skin only or temporary abdominal closure, and then transfer the patient urgently to a vascular center for revascularization.
Are there disadvantages to revascularizing first?
The main disadvantage is the logistical challenge of potentially transporting a critically ill, unstable patient between facilities or to a hybrid suite before addressing the bowel. It's a balance. Also, even after successful endovascular recanalization, patients might still need a laparotomy if signs of peritonitis persist, indicating some bowel was non-viable despite restoring flow.
Do you need to revascularize both the SMA and the CA?
Rarely indicated in the acute setting, the SMA is generally considered the more critical vessel to restore flow to.
Okay, let's talk specific open surgical techniques. What about for an embolus?
Open SMA embolectomy remains a good standard treatment option. This is typically done via laparotomy. The surgeon makes a transverse cut in the artery, arteriotomy, distal to the embolus, passes a Fogarty embolectomy catheter proximally and distally to remove the clot.
The Fogarty balloon catheter.
Exactly. They might use adjuncts like interarterial papaverine to prevent spasm afterwards, and postoperative anticoagulation with heparin is essential. They assess the runoff by feeling for a pulse or using a Doppler probe. Perioperative angiography, DSA, can be useful to confirm patency after the embolectomy.
And for acute thrombotic SMA occlusion due to underlying atherosclerosis.
The open options are different because you need to deal with the underlying plaque. Options include dividing the SMA distal to the occlusion and reimplanting it into the infrarenal aorta, performing a thromboendarterectomy, cleaning out the plaque, often with patch angioplasty to widen the origin, or performing a bypass graft from a healthy inflow source like the infrarenal aorta or sometimes iliac artery to the SMA distal to the atherosclerotic lesion.
Pre-op CTA helps plan that.
Yes, the pre-op CTA is crucial for identifying a suitable inflow source for bypass and planning the type of reconstruction needed, avoiding heavily diseased areas. A short synthetic graft from the infrarenal aorta is often preferred for bypass.
How is acute on chronic mesenteric ischemia treated? Is it similar?
Yes, the treatment approach is very similar to other forms of acute occlusion. Revascularization, either open or endovascular, is usually needed immediately. Rec 32, Class 1 Level C. The decision between open and endo depends on patient factors, presence of peritonitis, comorbidities, and the specific anatomical lesion. Is it more like an embolic event on top or acute thrombosis of a stenosis?
We keep coming back to intestinal viability assessment and the second look laparotomy.
Because it's so critical in AMI management, again, clinical judgment is the preferred method for assessing bowel viability during the initial laparotomy. Rec 7, Class 2A, Level C. But ischemic bowel can be tricky, paralytic, distended, hard to inspect safely, and laparoscopic manipulation might be risky.
So the second look
Is considered the safest way to definitively establish the extent of transmural ischemia. Liberal use is recommended because a significant number of patients require further bowel resection at that second look. The decision for a second look might be based on the surgeon's initial assessment, or if the patient fails to improve clinically within 48 hours in the ICU.
And again, avoid primary anastomosis if resection is needed initially.
Correct. Bowel recession in the setting of infarction and peritonitis carries a very high risk of anastomotic leakage, so primary anastomosis should be avoided.
This sounds like damage control surgery.
Exactly. Section 2.3.7 discusses applying damage control principles after mesenteric revascularization to evaluate and manage the visceral damage. This involves resecting non-viable bowel and potentially other organs, like a necrotic gallbladder, as needed, using staplers to close bowel ends, delaying anastomosis or stoma creation until a second or even third look laparotomy. The abdominal wall is often left unsutured or managed with a temporary abdominal closure system to facilitate planned repeat laparotomies.
What about creating a stoma versus eventual anastomosis?
A temporary stoma after extensive resection combined with parenteral nutrition is a common strategy. There's a potential argument that if effective revascularization has been achieved, performing an anastomosis later, not at the primary lab, might be beneficial for very extensive resections to avoid a high output stoma and reduce the risk of short bowel syndrome. However, this is controversial, as the risk of breakdown might still be high. There are no comparative studies on this specific issue.
Are antibiotics standard?
Yes. Patients requiring bowel resection for intestinal infarction should be treated with antibiotics. That's recommendation 8, a class 1 level A recommendation.
Okay, that covers the open surgical side. What about endovascular therapeutic options in AMI? How do you access the SMA?
Access is usually percutaneous, either via the femoral artery or sometimes the brachial artery in the arm. Brachial access might be preferred if the SMA comes off the aorta at a very sharp downward angle, or if the origin is heavily calcified, making femoral access difficult.
What if antegrade from femoral brachial access fails?
Then retrograde access through a surgically exposed SMA segment after laparotomy can be attempted, although often if laparotomy is needed, open revascularization might be preferred anyway. Sometimes local surgical exposure of the SMA origin itself is needed.
What endovascular techniques are used? Let's start with aspiration embolectomy.
Aspiration embolectomy is a treatment option primarily for embolic occlusion in patients without signs of peritonitis. The technique involves getting a catheter and wire system into the SMA, advancing an introducer sheath or guiding catheter proximal to the embolus, and then using a large syringe to aspirate the clot while withdrawing the catheter. Angiography is done to check the result, and repeated aspirations might be needed. There are also specialized aspiration catheters for smaller, more peripheral clots.
What about dissolving the clot? Local thrombolysis.
Local SMA thrombolysis is considered a viable alternative, again, usually in patients without peritonitis, if aspiration is incomplete or if there's distal embolization after initial treatment.
How is it done?
An infusion catheter, multi-side hole or end hole, is placed into the thrombus within the SMA. A thrombolytic agent, most often recombinant tissue plasminogen activator, RTPA, at a low dose, like 0.51 millhour or sometimes urokinase, is infused directly into the clot, typically over 24-72 hours. Patency is checked with angiography periodically. Bleeding complications can occur but are reported as uncommon and usually self-limiting with local infusion. Small residual emboli distally might be treated conservatively with anticoagulation alone. If there's an underlying stenosis, angioplasty or stenting might be needed after thrombolysis. If thrombolysis is contraindicated, for example, recent surgery, bleeding risk, then thrombectomy, aspiration or open, would be indicated.
What about fixing underlying blockages endovascularly, angioplasty and stenting?
Yes. Treating the underlying stenotic or occlusive lesion, typical in thrombotic AMI or acute on chronic, is often done during the same procedure after the acute clot is removed by aspiration or thrombolysis.
Timing relative to laparotomy.
The sequence under vascular intervention versus laparotomy depends on the patient's clinical state. Peritonitis needing urgent surgery versus stable enough for endo first. The technique involves getting stable wire access across the lesion, then performing angioplasty and stenting.
What kind of stents?
Balloon expandable stents are generally preferred for osteolesions right at the origin because they allow for precise deployment. Self-expanding stents might be better for more distal lesions or where there's significant vessel tortuosity or risk of dissection, as they are more flexible. Results are checked with angiography and sometimes pressure measurements across the treated segment.
You mentioned retrograde access earlier. Can you stent that way too?
Yes, retrograde recanalization and stenting of the SMA is an option if percutaneous antegrade access fails. This requires a laparotomy to expose the SMA distal to the blockage.
Why do this instead of open bypass if you're already doing a laparotomy?
It offers the advantage of being able to inspect the viscera directly, gain distal SMA control, and potentially avoid a bypass graft in the setting of potentially contaminated or necrotic bowel.
How is it done technically?
Usually involves a micropuncture of the SMA main trunk or a branch, passing a guide wire retrograde up through the occlusion into the aorta. Then, this wire can often be snared from the groin or arm to establish through and through access. Stenting is then typically performed antegrade over this wire, as standard devices are designed for antegrade use, and it might involve lower radiation exposure. The SMA puncture site is then closed surgically. Re-entry into the aorta from the SMA can sometimes be difficult and carries a risk of aortic dissection.
Okay, we've covered open and endovascular treatments. How do the outcomes compare, according to the guidelines analysis?
They reviewed 5 non-randomized studies comparing outcomes. Meta-analyses, visually summarized in figures 3 and 4 in the source, showed similar rates of bowel resection between open and endovascular approaches. However, endovascular therapy was associated with lower 30-day mortality. This leads to recommendation 9, which is class 1 level B, favoring endovascular therapy first line when feasible based on mortality outcome.
But caveats.
Yes, a major caveat is the potential for selection bias. Endovascular therapy might have been preferentially used in less sick patients or those without peritonitis, which could skew the mortality results. The reported rates of successful recanalization were actually similar between the two approaches in these studies.
What about follow-up after treatment for AMI?
It's a bit difficult because follow-up data often lumps AMI and CMI patients together after stenting. There's a significant risk of incident restenosis reported. One study cited 36% after a mean of 29 months, but this included CMI patients.
Is stent reocclusion worse after AMI than CMI?
Likely, yes. The risk of dying from recurrent acute ischemia if an SMA stent placed for AMI reoccludes is probably higher than if a stent placed for CMI reoccludes, because patients treated for AMI often have less well-developed collateral circulation compared to chronic patients. Also, emergency stenting for AMI might be performed under suboptimal conditions.
So surveillance is needed.
The guidelines suggest that patients with an SMA or CA stent placed for either CMI or AMI should be followed with imaging, like Duplex Ultrasound, DUS, or CTA, due to this high restenosis risk. However, the optimal follow-up schedule varies widely in practice. Examples given are imaging before discharge, then 6 million annually, or more frequently like 1 milli, 3 million, 6,012 meters, then yearly.
What about after treatment for embolic disease?
For treated embolic disease, whether open embolectomy or endovascular aspiration analysis, specific mesenteric arterial imaging follow-up is probably not needed after the initial 30-day period, assuming the underlying cardiac source, like AF, is being appropriately managed.
Let's talk about long-term medical treatment for survivors of AMI.
Lifelong medical treatment is definitely necessary. The type depends on the cause of the AMI.
For a thrombotic occlusion due to atherosclerosis,
Best medical therapy against atherosclerosis is recommended. This includes smoking cessation, an antiplatelet agent like aspirin or clopidogrel, and a statin. These are Class 1 recommendations, Rex 11 for statins based on general CV outcomes, Rec 13 for best medical therapy overall, Level C evidence specifically for mesenteric disease. Statins, based on large meta-analyses, show a significant reduction in total mortality linked to LDL reduction.
single or dual antiplatelet therapy.
There's no specific data for secondary prophylaxis in mesenteric arterial disease itself regarding dual versus single antiplatelet. Data from peripheral carotid coronary interventions doesn't show significant superiority for dual therapy long-term and notes increased bleeding risk. So typically single antiplatelet lifelong unless other indications exist.
And for embolic occlusion, usually from atrial fibrillation.
Lifelong anticoagulation with a vitamin K antagonist, VKA like warfarin, or a new oral anticoagulant, NOAC/UOAC, is usually indicated for non-valvular AF, Rec 11 Class 1 Level B. Anticoagulation for AF significantly reduces the risk of recurrent embolism, Rec 12 Class 1 Level A.
Any role for dual antiplatelet after endovascular treatment for AMI.
Recommendation 14 suggests dual antiplatelet therapy might be considered for a period of 3 to 12 months after endovascular revascularization for AMI. However, this is a Class 2B Level C recommendation, indicating less certainty and reliance on expert opinion or extrapolation from other vascular beds, despite the Class 1 Level B mortality benefit cited earlier for endo versus open.
Okay, that wraps up our detailed look at AMI. To recap, we explored the different presentations, embolic versus thrombotic, the limited utility of early labs, but the critical role of CTA. We covered treatments from open surgery, embolectomy bypass, to endovascular, aspiration and lysis stenting, the preference for revascularization before resection, the importance of second-look laparotomy, and damage control. We noted similar resection rates, but potential lower short-term mortality with endo, Rec 9 Class 1 Level B, discussed follow-up needs, and outlined lifelong medical management, antiplatelet statins for thrombosis, anticoagulants for embolism. Let's now transition to the management of chronic mesenteric ischemia, CMI.
Right. CMI, as we established, is most commonly caused by atherosclerosis. The presentation is often insidious, leading to delays in diagnosis. The classic symptoms are that postprandial abdominal pain or abdominal angina, leading to food avoidance, sotophobia, and progressive weight loss.
Any atypical symptoms?
Yes. Some patients might present with more constant abdominal discomfort, nausea, vomiting, diarrhea, or constipation. These atypical symptoms might actually indicate end-stage ischemia with a higher risk of progressing to bowel gangrene.
What might you find on history and exam?
The clinical history and physical exam may reveal associated atherosclerotic disease elsewhere, coronary arteries, peripheral arteries, maybe an abdominal aortic aneurysm. An epigastric bruit might be present, but it's not very specific or sensitive. Laboratory findings are generally nonspecific, perhaps showing signs of malnutrition like anemia, leukopenia, electrolyte abnormalities, or hypoepidemiology.
Diagnosis is often delayed, you said.
Yes, frequently patients undergo extensive investigations looking for malignancy or are classified as having functional abdominal disorders before CMI is finally considered and diagnosed. A high index of suspicion is really important.
Remind us again about the anatomy and why symptoms typically require multivessel disease in CMI.
It goes back to those three main mesenteric arteries, CA, SMA, IMA, and their extensive collateral pathways, like the pancreaticoduodenal arcades and the marginal artery row and arc. These collaterals provide a robust arterial supply, meaning that significant stenosis or even occlusion of just one vessel is often well compensated for and doesn't cause ischemia.
So single vessel stenosis is common but usually asymptomatic.
Exactly. Studies show single vessel stenosis is found in up to maybe 18% of the general population undergoing imaging for other reasons, but the diagnosis of CMI is much rarer. Symptoms usually do not develop until at least two of the three mesenteric arteries are significantly stenosed or occluded.
Unless it smells.
Right. The exception is single vessel CA stenosis caused by external compression from the median arcuate ligament in males, which can cause symptoms, typically epigastric pain, due to the compression itself rather than just atherosclerosis.
Okay, so how is CMI diagnosed? Starting with imaging.
Given the potential for delayed diagnosis, non-invasive imaging should be performed first if CMI is suspected. Duplex Ultrasound, DUS, is recommended as the first-line examination, Rec 15, Class 1 Level B.
How reliable is DUS?
It's considered reliable for detecting significant stenosis, particularly in the SMA and CA origins. It relies on measuring blood flow velocities, specifically peak systolic velocity, PSV, and end diastolic velocity, EDV. Table 3 in the guidelines provides specific criteria, citing studies like Moneta 1993 and Aburama 2012. For example, for the SMA, a PSV over 275 centimeters suggests 70% stenosis with high sensitivity and specificity. For the CA, a PSV over 200 centimeters suggests 70% stenosis.
Does the patient need to be fasting?
Yes, ideally the patient should be fasting because blood flow changes significantly after eating, making interpretation complex. Sometimes postprandial testing after a standardized test meal can be helpful to see if velocities change appropriately. An abnormal response might justify further imaging.
Limitations of DUS.
It's operator dependent, can be challenging in obese patients or those with lots of bowel gas, and visualizing the IMA and the distal SMA can be difficult. Interpretation also needs to consider the respiratory cycle and the status of the other vessels.
So if DUS is suggestive or suspicion is high, what's next? CTA.
Yes, computed tomography angiography, CTA, is recommended in patients with a moderate to high suspicion of CMI, Rec 16 Class 1 Level C. Its purpose is twofold: to accurately map the occlusive disease in all three vessels and their branches, and also to detect or exclude other potential intra-abdominal causes for the patient's symptoms.
Better than MRA.
A recent study cited found CTA superior to magnetic resonance angiography, MRA, for overall imaging quality of the mesenteric vessels, and particularly better for visualizing the IMA and more peripheral vessels.
When might MRA be used?
MRA may be considered an alternative to CTA for diagnosis. Rec 17 Class 2B Level C. There's no clear demonstrated superiority over CTA, and sensitivity might be lower for CA and IMA visualization. It's often preferred in younger patients to avoid radiation, or in those with significant renal insufficiency or a strong contrast allergy where CTA might be relatively contraindicated.
Okay, so imaging can show stenosis. But you mentioned earlier that stenosis doesn't always equal ischemia causing symptoms. How do you prove functional compromise?
That's a really critical point. The presence of vessel stenosis on imaging is no proof of actual ischemia sufficient to cause the patient's symptoms. The clinical history of CMI overlaps significantly with many other disorders: pancreas, gallbladder, stomach, duodenum problems, even functional bowel disorders. So ideally, you need some proof of functional compromise.
What functional tests are available? Gastric tonometry.
Gastric tonometry was a promising technique. It measures the partial pressure of carbon dioxide, PCO2, in the gut lumen using a special nasogastric or nasojejunal catheter. Increased luminal PCO2 indicates local tissue acidosis from anaerobic metabolism due to ischemia.
How does it work?
The CO2 stems from lactic acid being buffered locally. The PCO2 gradient between the lumen and blood increases sharply when blood flow drops below about 50% of normal. Studies showed good accuracy for diagnosing CMI using tonometry either during an exercise test or after standard meals. Sensitivity 76-92%, specificity 77-92%.
But practical issues.
Yes, the main drawback is that the technique was complicated, time-consuming, and prone to errors. Crucially, the manufacturer stopped producing the specific TonoCap device needed, so its current availability and future are uncertain. It's not widely used now.
Any blood tests, serological markers.
Most studies on markers like IFABP, alpha-GST, LEVBP have been done in the context of AMI or NOMI. A pilot study in CMI patients found these were not reliable for detecting chronic ischemia. So currently, there are no reliable serological markers available for CMI detection. Diagnosis relies heavily on the combination of typical symptoms, multivessel disease on imaging, and exclusion of other causes.
Okay, another micro recap. We've now shifted to chronic mesenteric ischemia, CMI. We highlighted its insidious nature, classic symptoms like abdominal angina and weight loss, and the diagnostic challenges. Key point. Extensive collaterals mean symptoms usually require at least 2 vessel disease. Diagnosis starts with DUS, Rec 15, Class 1 Level B, confirmed and mapped with CTA, Rec 16, Class 1 Level C, or sometimes MRA, Rec 17, Class 2B Level C. Crucially, we discussed the need for functional proof of ischemia beyond just seeing stenosis, reviewing the limited utility of gastric tonometry now and the lack of reliable blood markers. With diagnosis covered, let's explore the treatment options recommended for CMI.
All right. The overall goal of treatment for CMI is revascularization. The aims are symptom relief, improving quality of life, allowing weight restoration, and potentially improving survival by preventing progression to acute ischemia and bowel infarction.
Is conservative management an option?
A conservative approach relying on long-term parenteral nutrition is explicitly not recommended by the guidelines. This is generally associated with further deterioration, risk of bowel infarction, and catheter-related sepsis. Excessive delays in achieving definitive revascularization are considered detrimental.
What about treating asymptomatic disease? Prophylactic revascularization.
This is controversial and rarely performed. One report suggested a possible role in patients with severe 3-vessel disease who have difficult access to medical care, but it's not standard practice. If a conservative approach is chosen for asymptomatic severe disease, these patients need close monitoring and counseling with a very low threshold for intervention if any symptoms appear.
Is nutritional support helpful before revascularization?
Despite patients often being malnourished, there's little evidence supporting specific enteral or parenteral feeding strategies before fixing the blood flow. Experimentally, enteral nutrition might even increase metabolic demand and contribute to necrosis if perfusion is severely impaired. So, revascularization is the mainstay, after which oral nutrition can usually resume.
So who gets revascularized? What are the specific indications?
Okay, recommendation 18 is key. In patients with symptomatic CMI caused by multivessel occlusive disease, revascularization is recommended. This is a strong recommendation, Class 1, Level A.
What about single vessel disease?
Recommendation 19 addresses this. In patients with symptomatic CMI caused by single vessel stenosis, and it's not MELS, revascularization might be considered, but only if there is both clinical and functional proof of ischemia. This is a Class 2A Level C recommendation, so weaker evidence needs careful consideration.
And MELS, median arcuate ligament syndrome.
That's recommendation 20. In patients with symptomatic CMI caused by single-vessel CA stenosis due to external compression, MALS, surgical release of the median arcuate ligament is recommended. This is Class 1 Level C, so surgery to release the compression is the primary treatment there.
Okay, so for atherosclerotic CMI needing revascularization, the big question is, open surgery versus endovascular. What do the guidelines say?
This is a major point of discussion. There are no randomized controlled trials, RCTs, directly comparing open versus endovascular approaches specifically for CMI. The Guideline Writing Committee performed a meta-analysis described verbally in Figure 5.
What did it show?
It showed conflicting results regarding early mortality. Single-center cohort studies from highly specialized centers showed no significant difference in perioperative mortality between open and endo. However, analysis of large U.S. administrative databases, like the nationwide inpatient sample, did show lower mortality after endovascular treatment.
But potential bias in the administrative data.
Yes, likely significant selection bias, with endovascular potentially being used in lower-risk patients in those large datasets. What is clearer from the evidence, though, is that mesenteric bypass, open surgery, offers improved long-term patency, with lower rates of reintervention needed and better freedom from recurrent symptoms compared to endovascular treatment.
So a trade-off.
Exactly. It remains to be definitively proven that endovascular treatment provides similar long-term durability and clinical improvement. RTTs are warranted but difficult due to low patient numbers, requiring collaboration between major centers. This leads to recommendation 21, which is Class 1 Level B. In patients with CMI needing revascularization, the superior long-term results of open surgery must be offset against a possible early benefit of endovascular intervention with regard to peri-procedural mortality and morbidity.
So the choice depends on the individual patient and anatomy.
Precisely. It requires careful discussion regarding short-term risks versus long-term durability.
Let's delve into endovascular revascularization techniques for CMI. Which vessel is the main target?
Recommendation 22 states the SMA is the main primary target for revascularization whenever possible. Class 1 Level B, though cited in the open surgery section, it applies here. Revascularization of the CA or IMA is also performed, particularly if the SMA is chronically occluded or anatomically unsuitable for intervention.
What factors influence treatment selection?
Vessel diameter, the extent of stenosis or occlusion, presence of tandem lesions, degree of calcification, amount of thrombus, and the existing collateralization all play a role. Angioplasty and stenting are generally most effective for relatively short focal stenosis or occlusions with minimal to moderate calcification or thrombus. It's possible for longer or more calcified lesions, but maybe less optimal.
What about the CA specifically?
CA lesions treated with angioplasty and stenting have been associated with higher restenosis rates. Importantly, CA stenting should not be performed if there is active compression by the median arcuate ligament. It is an option if there's no compression or if the ligament has already been surgically released.
Do you need to stent both the CA and SMA?
There's no strong evidence supporting routine two-vessel stenting, CA plus SMA, over single-vessel stenting. If both are options in a symptomatic patient, SMA stenting is generally preferred over CA stenting. CA intervention might be considered in higher-risk patients if SMA recanalization fails, or if the chance of SMA success seems low, for example, heavy calcification, long occlusion. Sometimes CA stenting can serve as a bridge to open bypass or allow for later retrograde SMA stenting.
What about the IMA?
Evidence for IMA angioplasty is limited mostly to case series. The indication for targeting the IMA remains unclear.
Is there an endovascular first trend?
Yes, the guidelines acknowledge that an endovascular first approach is used in many centers, often regardless of the patient's baseline surgical risk. However, certain anatomical factors make endovascular treatment more difficult or risky, like severe centric calcification, flush occlusions right at the origin, or very long lesions extending into the mid-SMA. Stenting might still be possible, but with a higher risk of suboptimal result, restenosis, or complications.
Angioplasty alone or always stent?
Balloon angioplasty alone was the primary method historically, but it had high restenosis rates, around 50%. Recommendation 23 is clear. Routine mesenteric stenting should be used as opposed to plain balloon angioplasty, Class 1 Level C. Stenting significantly improves patency compared to angioplasty alone.
Covered stents versus bare metal stents.
An RCT was ongoing at the time of the guideline publication. Recommendation 24 suggests that covered stents as opposed to bare metal stents may be considered, Class 2B Level C. The idea is they might reduce restenosis, but definitive evidence was pending.
Okay, now turning to open surgery for CMI. When is it primarily used or preferred?
Open surgery is primarily considered in patients with mesenteric lesions that are anatomically unfavorable for endovascular treatment, or in those who have had failed percutaneous intervention or perhaps recurrent in-stent stenosis or occlusion after previous endo attempts.
Mortality rates.
Mortality rates under 3% have been reported for elective open CMI surgery in large tertiary centers, though it might be higher in patients presenting late with impending infarction. Surgery may also be preferable for non-atherosclerotic causes like vasculitis, neurofibromatosis, or mid-aortic syndrome.
So specific indications for considering open surgery.
Recommendation 25 outlines these, Class 2A Level B. Open revascularization should be considered in situations like highs failed endovascular therapy, 2, patients who are not good candidates for endovascular treatment due to extensive occlusion or calcification precluding safe intervention, or 3, younger patients with complex non-atherosclerotic lesions.
What about preoperative evaluation before open surgery?
Need to assess surgical risk, nutritional status, and the anatomical factors influencing the choice of reconstruction. A comprehensive evaluation of cardiac, pulmonary, and renal function is needed due to frequent comorbidities, but this should not unduly delay treatment in urgent or semi-urgent cases. Routine cardiac catheterization isn't necessary unless indicated by standard cardiac guidelines. While nutritional status and smoking cessation are important, time is often critical, and revascularization must not be delayed significantly for optimization.
What are the main open surgical techniques used?
Planning involves choosing the incision type, transperitoneal versus retroperitoneal, the conduit, vein versus prosthetic graft, the graft configuration, antegrade from the supracoeliac aorta versus retrograde from the infarenal aorta or iliac artery, the enclosed source, and the number of vessels to bypass, single versus multiple. It needs to be tailored to the patient's anatomy and physiological risk.
Retrograde versus antegrade bypass.
Patients with less physiological reserve, due to age, cachexia, severe organ dysfunction, are often not good candidates for supracoeliac aortic reconstructions, antegrade bypasses. They might be better suited for extra anatomical reconstructions originating from the infarenal aorta or iliac artery, retrograde bypasses, which are generally less physiologically demanding.
You mentioned retrograde open mesenteric stenting, ROMS, earlier.
Yes, that's described in section 3.2.7.3. It's a hybrid technique involving surgical exposure of the SMA below the pancreas, gaining retrograde access into the SMA, and then treating the proximal stenosis or occlusion with angioplasty and stenting, often guided fluoroscopically. The wire can be snared to work from the groin arm. It avoids a formal bypass. Puncture site closure requires sutures or a patch. Re-entry into the aorta can be tricky.
Any other open techniques? Transaortic endarterectomy.
Yes, transaortic endarterectomy, cleaning plaque directly from the aorta around the mesenteric origins, is rarely used now but might be considered in specific situations like a hostile abdomen, previous surgeries, contamination, radiation. A recent publication cited showed reasonable outcomes, but it's technically demanding. Direct mesenteric endarterectomy, cleaning plaque from the mesenteric vessel itself, is another alternative.
Okay, let's talk outcomes and follow-up after CMI treatment. How are outcomes reported?
Most studies report 30-day or in-hospital outcomes like mortality and morbidity. Long-term outcome data, especially beyond 5 years, is often limited or incomplete.
What do comparisons show regarding long-term results?
As mentioned with Rec 21, reviews comparing open versus endo generally find higher technical success rates initially for open surgery, although endo success improved with experience. While 30-day mortality rates might be similar in some analyses or lower for endo and administrative data, the medium-term restenosis and reintervention rates are significantly lower for open surgery. Primary graft patency at 1 and 2 years is reported as much higher for open bypass compared to endovascular stenting. Secondary patency after reintervention is also better with open surgery.
Does completeness of revascularization matter for open surgery?
One retrospective open surgery study, 80 system procedures, found that while long-term survival and overall patency weren't significantly different between complete, e.g. bypassing both SMA and CA if diseased, versus incomplete revascularization, the freedom from recurrent gastrointestinal symptoms at 10 years was significantly better with complete revascularization, 79%, Zalissi 65%.
So what's the value of routine follow-up imaging after CMI treatment? Is it recommended?
This is another area of uncertainty. It's unknown if routine imaging surveillance, using duplex ultrasound, CTA, or MRA, actually provides a clinical benefit. If you find asymptomatic restenosis or graft stenosis, the optimal management isn't clear. Do you intervene prophylactically or wait for symptoms?
Do most restenosis become symptomatic?
One study of endovascular patients found 36% restenosis at mean 29 months. Of those treated, most, 24 out of 30, had recurrent symptoms. Only 6 were treated preemptively for preocclusive lesions. Another report following patients with DUS after SMA stenting also found most reinterventions were triggered by symptoms. This suggests the majority of cases needing reintervention present with recurrent symptoms.
So the guideline stance on routine follow-up.
They conclude there is little evidence that routine follow-up, either clinical assessment alone or with imaging, is beneficial. While peripheral artery disease guidelines might recommend DUS every 6-12 months, there's no solid evidence supporting this specifically for mesenteric revascularization. The decision on follow-up strategy needs to consider the potential value for the individual patient against the use of healthcare resources.
Okay, what about medical treatment and prevention for CMI patients after revascularization?
Standard secondary prevention for atherosclerosis is key. Risk factor modification is recommended, Rec 26 Class 1 Level C. Smoking cessation is strongly recommended, Rec 27 Class 1 Level B. Medical therapy targeting atherosclerosis risk factors, statins, BP control, diabetes management is recommended, Rec 28 Class 1 Level C.
Antiplatelet therapy.
Yes, antiplatelet therapy, usually single agent like aspirin or clopidogrel, is recommended after revascularization for CMI, Rec 29 Class 1 Level A.
Dual antiplatelet.
Similar to AMI, dual antiplatelet therapy might be considered for a period of 3 to 12 months after endovascular revascularization for CMI, Rec 30, Class 2B Level C. Again, a weaker recommendation based on extrapolation.
Finally, for CMI, how should care be organized?
Recommendation 31 emphasizes that patients with CMI should preferably be investigated and treated at specialized centers. These centers should be able to offer a multidisciplinary assessment involving gastroenterologists, radiologists, vascular surgeons, etc., and critically should have expertise and availability of both open and endovascular treatment options, Class 1 Level C.
That concludes a very thorough look at CMI. To recap, we covered diagnosis, do US first, then see TAMRA, focusing on multivessel disease, the challenge of proving functional ischemia, and the mainstay of treatment being revascularization for symptomatic multivessel disease, Rec 18. We discussed indications for single vessel disease and MALS, Recs 1920. We compared open, better long-term patency versus endo, potential early benefit, Rec 21, detailed techniques for both, stenting preferred over angioplasty alone, Rec 23, indications for open, Rec 25, look at outcomes, the uncertain benefit of routine imaging follow-up, and reinforce risk factor modification, Recs 2630, and treatment at specialized centers, Rec 31. Now let's move to non-occlusive mesenteric ischemia, NOMI.
Right, NOMI. This is often a very difficult condition to diagnose, and it's common in critically ill patients. The traditional definition involves angiography showing diffuse mesenteric vasoconstriction without any mechanical occlusion of the main arteries. It frequently involves smaller vessels or branches and sadly is often lethal. A high index of suspicion is absolutely crucial, especially in that critically ill patient population.
What's the underlying cause or pathogenesis?
And NOMI is fundamentally a hypoperfusion syndrome. It occurs when severe ischemia of the intestines develops, despite the main mesenteric arteries being patent. The primary mechanism is severe vasoconstriction of the mesenteric circulation, which happens in response to reduced effective blood volume or low cardiac output.
What kind of clinical scenarios lead to this?
It's prevalent in critical illness, think sepsis, severe burns, pancreatitis, acute renal failure, especially patients on renal replacement therapy. It's also seen after major heart or aortic surgery following massive fluid resuscitation and can be associated with certain medications, particularly vasopressors, but also cocaine, alpha-adrenergic agonists, and historically, digitalis.
Can it happen in patients with underlying atherosclerosis?
Yes. It can occur in patients with pre-existing, perhaps asymptomatic mesenteric atherosclerosis. This is sometimes termed acute on chronic OMI. Essentially, these patients are more vulnerable to drops in perfusion. The core issue is that during low-flow states, blood flow gets actively redistributed away from the gut to protect the brain, heart, and kidneys. And this splanchnic vasoconstriction can be aggravated by reflex mechanisms, medications, ongoing sepsis, or even disseminated intravascular coagulation, DIC.
Interesting. Hypertension is common in other mesenteric diseases, but maybe less so in NOMI.
That's an observation mentioned the prevalence of hypertension was low in some NOMI series, possibly because these patients are often critically ill and hypotensive from their underlying condition, shock, sepsis, etc.
Okay, diagnosis, you said it's difficult.
Yeah.
Symptoms.
Symptoms are very nonspecific. Abdominal pain, distension, nausea, vomiting, diarrhea, and these might be completely masked in sedated, ventilated ICU patients. So you need that high index of suspicion in any critically ill patient with risk factors who develops new gastrointestinal symptoms or signs, or just fails to improve as expected.
Are lab markers helpful for NOMI?
Again, unfortunately, no specific laboratory marker is accurate. Lactate, IFABP, D-dimer, they're all nonspecific and often late findings in NOI, similar to occlusive AMI.
So imaging is key again. What does CTA show?
CTA is often the first-line imaging test performed in critically ill patients with suspected intra-abdominal catastrophe. In NOMI, the findings might include patent main mesenteric arteries, which is key, but signs of bowel distress like reduced contrast enhancement of the bowel wall, intramural gas, pneumatosis intestinalis, chordomesenteric venous gas, ascites, thickened bowel wall, or dilated small bowel loops. However, visualizing the characteristic small vessel vasoconstriction itself can be difficult on CTA.
So what's considered the gold standard for diagnosing NOMI?
Traditionally, digital subtraction angiography, DSA, meaning conventional catheter angiography, has been considered the gold standard for diagnosis. This is recommendation 34, class 2A level C.
Why DSA?
Because it can directly visualize the diffuse, severe vasoconstriction or spasm of the mesenteric arteries and their branches, which is the hallmark of NOMI, in the absence of a fixed occlusion. Diagnosis is often made by excluding occlusive causes after other imaging like CTA and then potentially confirming with DSA if the patient is stable enough and it would change management.
You mentioned intra-abdominal hypertension, IAH, and abdominal compartment syndrome, ACS, earlier. How do they relate to NOMI?
There's a very strong link. The World Society of the Abdominal Compartment Syndrome, WSACS definitions are relevant here. IAH is defined as a sustained intra-abdominal pressure, IAP, above 12 mmHg, which is known to negatively affect bowel perfusion. ACS is defined as a sustained IAP above 20 mmHg associated with new organ dysfunction or failure.
And this happens in critically ill patients.
Yes. IAH and ACS are common in patients undergoing massive resuscitation for shock, severe heart failure, sepsis, major hemorrhage, pancreatitis, etc. The increased pressure directly compresses the mesenteric veins and arteries, impairing blood flow and leading to bowel ischemia, essentially causing or exacerbating NOMI.
So monitoring IAP is important.
Critically important. Recommendation 35 is Class 1 Level B. IAP should be measured routinely in patients at risk of developing IAACS, usually via a bladder catheter. And if IAH develops, action should be taken according to a predefined protocol.
Okay, another quick micro recap. We've covered non-occlusive mesenteric ischemia, NOMI, a challenging diagnosis mainly in critically ill patients, defined by intestinal ischemia despite patent main arteries driven by severe vasoconstriction in low flow states. We noted non-specific symptoms in labs. While CTA shows bowel changes, DSA has been the gold standard for visualizing vasoconstriction. Rec 34, Class 2A Level C. We stressed the crucial link with intra-abdominal hypertension, IAH, and compartment syndrome, ACSLE, highlighting the importance of IAP monitoring in at-risk patients. Rec 35, Class 1 Level B. Now let's discuss the treatment strategies for NOMI.
Okay, treatment for NOMI. It really starts with prevention, if possible. The guidelines mention a study analyzing NOMI after cardiac surgery found a strong association with intraoperative use of vasopressors and also the lowest intraoperative mean arterial pressure. It's a bit unclear whether it's the hypotension itself or the vasopressors used to treat it, or maybe both, that primarily drives NOMI in that setting.
What about treating underlying arterial narrowing?
Yes, this is an important point. An autopsy study of fatal NOMI cases found that 40% of patients who had non-occluded main vessels actually had significant underlying SMA narrowing that could potentially have been treated by stenting. These patients tended to be older and often had concomitant CA stenosis.
So fix underlying stenosis even in NOMI.
It suggests that identifying and treating significant stenosis of the mesenteric arteries should be considered in patients suspected of having NOMI. This is recommendation 36, Class 1 Level C. Patients on renal replacement therapy, for instance, often have heavily calcified mesenteric arteries, making them very vulnerable to hypotension. If such a patient develops ischemia due to hypotension-hypovolemia superimposed on a stenosis, you could argue it's NOMI, or perhaps acute on chronic ischemia. The lines can blur. Treating the stenosis might improve their tolerance to low-flow states.
And managing IAACS.
Absolutely vital. If patients develop IAH, IAP 12 mmHg, recommendation 37, Class 1 Level B, advises a proactive approach with medical management, EKNM, sedation, paralysis, fluid balance optimization, and rectal tube drainage to try and prevent progression to ACS and NOM.
What if ACS does develop?
If ACS develops, IAP 20 mmHg plus organ dysfunction, then recommendation 38, Class 1 Level B, states that decompression laparotomy should be performed promptly to prevent or treat NOA. Opening the abdomen effectively reduces the intra-abdominal pressure and can rapidly improve organ function, including bowel perfusion. This is particularly true when IAH occurs on top of an underlying hypoperfusion state.
Okay, what about directly treating the vasoconstriction itself?
For life-threatening NOMA, the guidelines recommend, Rec 39, Class 1 Level C, that patients should be taken to an operating room environment that has capacity for both open and endovascular surgery, like a hybrid OR. Because there, you can perform diagnostic angiography, DSA, potentially place a stent if a significant stenosis is found linking back to Rec 36, and/or administer intra-arterial vasodilators directly into the mesenteric circulation, and/or proceed to laparotomy for bowel assessment and resection if needed, all in one setting.
What vasodilators are used?
The traditional therapy involves intra-arterial infusion of vasodilators directly into the SMA via a catheter placed during angiography. Papaverine is commonly mentioned, but also nitroglycerin, prostaglandin E1, or glucagon have been used. A usual papaverine regimen might be an initial bolus followed by a continuous infusion for 24-72 hours.
Is the evidence strong for this?
Not really. The guidelines note there are no contemporary or comparative studies evaluating different vasodilators, dosages, or infusion regimens. This makes precise recommendations impossible. It's based on historical practice and physiological rationale. There's also a risk of causing systemic hypotension when giving potent vasodilators, which is dangerous in already critically ill patients, but sometimes it's the only option to try and reverse the vasospasm and save the bowel.
Any adjunct treatments?
Antibiotic treatment is often suggested due to the expected loss of gut mucosal integrity and risk of bacterial translocation, supported by animal experiments. Anticoagulation is also sometimes suggested, though the rationale is less clear in pure NOMI without thrombosis. Again, no controlled studies compare these pharmacological adjuncts.
What's the outcome typically like for NOMI?
As mentioned, mortality is reported to be very high, 58%, in one large series of AMI patients where NOMI wasn't clearly separated out. Independent risk factors for ICU mortality identified include increasing age, higher severity of illness scores like SOFA score, and higher plasma lactate levels, Ferg 2.7 millimol.
Any protective factors found?
Interestingly, one study found that a prior history of peripheral vascular disease or receiving initial surgical treatment, laparotomy, were independent protective factors. This probably reflects a higher index of suspicion and potentially earlier diagnosis and intervention in those groups.
What about NOMI after cardiac surgery?
Risk factors identified preoperatively include renal insufficiency and age over 70. Postoperatively, needing intra-aortic balloon pump support and having a high serum lactate, 5 millimol, were associated risk factors. Endothelin 1 levels were found to be higher in NOMA patients, suggesting a potential future diagnostic marker, perhaps. The reported proportion of patients developing NOMI after cardiac surgery varies hugely in the literature, 0.3% to 9%, likely reflecting differences in diagnostic intensity or patient selection. And similar to AMI, a normal D-dimer probably helps exclude NOMI due to its high sensitivity.
That covers the challenging entity of NOMI. To recap, NOMI is critical illness-associated bowel ischemia from vasoconstriction despite patent arteries. Diagnosis is tough, relying on suspicion, CTA findings of bowel distress, and potentially DSA confirmation, Rec 34. The link to IAACS is critical, mandating IAP monitoring and intervention, Recs 35, 37, 38. Treatment involves prevention, addressing underlying stenosis, Rec 36, managing IAACS, and potentially using intra-arterial vasodilators in a specialized setting, Rec 39, though evidence for the latter is limited. Mortality remains very high. Let's move on to the next major category, mesenteric venous thrombosis, MVT.
Okay, MVT. This is the second most common cause of mesenteric ischemia overall. Diagnosis can often be difficult, and the presentation is typically more gradual than acute arterial occlusion. MET generally refers to thrombosis within the superior mesenteric vein, SMV, sometimes extending into the portal vein, PV, or splenic vein, SV. Concomitant involvement of multiple segments is common, with PV and SMV involvement being the most frequent pattern.
What's the scope for MVT in these guidelines?
They focus specifically on MVT that causes symptoms or mesenteric ischemia. They explicitly do not cover patients with truly asymptomatic MVT found incidentally, suggesting referral to general venous thrombosis guidelines, nor isolated hepatic vein thrombosis, Buchiari, isolated portal vein thrombosis if it's definitely not causing mesenteric ischemia, or aneurysms of the portal vein.
What causes MVT? What's the etiology?
MVT, like other venous thromboembolic disease, VTE, adheres to Virchow's triad. Factors promoting a prothrombotic state, local vessel wall injury or inflammation, and venous stasis. Most MVT cases are considered secondary, meaning there's an identifiable predisposing local or systemic condition.
What kind of conditions?
Thorough investigation can identify systemic prothrombotic factors in about 60-70% of patients, and local factors in about 30-40%. Systemic factors include inherited thrombophilias like factor V Leiden, prothrombin G2210A gene mutation, deficiencies of antithrombin protein C or protein S, and acquired conditions like myeloproliferative neoplasms, MPNs often associated with the JAK2 V617F mutation, and antiphospholipid antibody syndrome, APLS. Local factors include intra-abdominal inflammation, pancreatitis, diverticulitis, inflammatory bowel disease, malignancy, especially abdominal cancers, recent abdominal surgery, or trauma.
What if no cause is found?
In about 5–15% of cases, investigations fail to identify a clear cause. This is sometimes termed primary or idiopathic MVT, though it's often associated with maybe a single prothrombotic risk factor without an obvious local trigger.
So screening for underlying causes is important.
Yes, very important. Recommendation 40 is Class 1 Level B. Investigations for abdominal cancer, inflammatory disease, and myeloproliferative neoplasms should be performed in patients presenting with MVT.
What about thrombophilia testing?
Recommendation 41, Class 2A Level B, suggests investigations for concurrent risk factors for thrombosis, which would include thrombophilia, should be considered. Recommendation 42, Class 2A Level C, specifically says investigation for APLA should be considered in patients with recurrent MVT or a history of recurrent fetal loss. And Recommendation 43, Class 2B Level C, states that genetic assessment of thrombophilia may be considered. Given the high rate of finding these factors, many experts do tend to screen for thrombophilia, although whether finding a specific inherited thrombophilia necessarily changes the duration of treatment beyond standard VTE guidelines is still debated. If no local cause is found, definitely consider an underlying MPN.
How does MVT typically present clinically? Acute versus chronic.
Acute versus chronic MVT are often seen as successive stages of the same process. Acute onset is usually defined as symptoms present for less than 4 weeks. While they share underlying causes, the management differs.
Symptoms of acute MVT.
Abdominal pain is the most common symptom, but its character can be variable, sometimes insidious, especially with more peripheral thrombosis. Nausea, vomiting, diarrhea, and sometimes bloody stools, if the bowel mucosa is significantly involved, can occur. The intensity and severity of pain often correlate with how proximal the thrombosis is and its extent. Isolated portal vein thrombosis tends to have fewer symptoms than SMV involvement.
Is the time course different from AMI?
Yes, generally acute MVT has a more protracted time course compared to acute arterial ischemia. Symptoms often persist for 2–3 days in over 75% of patients before diagnosis is made. Diffuse abdominal pain might have been present for days or even weeks. Unlike isolated PVT, SMV involvement is associated with symptoms in the vast majority of cases, around 92%.
What about chronic MVT?
Chronic MVT might be asymptomatic or cause only mild intermittent abdominal pain or fatigue. It's often found incidentally on imaging or when complications like portal hypertension, leading to varices, ascites, or hypersplenism develop. Interestingly, if patients with chronic MVT develop GI bleeding from varices, their outcome is often better than patients bleeding from varices due to cirrhosis, possibly because they tend to be younger and have normal underlying liver function.
Any specific MVT syndromes? Pylophlebitis.
Yes, septic portal vein thrombosis, or pylophlebitis, presents with fever, abdominal pain, and often jaundice. It's typically associated with an intra-abdominal infection focus, like diverticulitis, appendicitis, cholecystitis, or pancreatitis, although the primary focus can sometimes be overlooked.
Does the location of the clot affect the long term?
Yes, the risk of developing persistent venous occlusion and chronic MVT seems higher if the initial thrombus is located more peripherally in the mesenteric veins compared to more central PVS-MV junction thrombosis.
How do you differentiate MVT from arterial ischemia clinically?
There can be subtle clinical differences, but honestly, differentiation can be very difficult clinically in the acute setting, especially early on. The source mentions Table 5, which we don't have, summarizes these differences. Broadly, acute venous tends to have non-specific abdominal complaints billing over days, whereas acute arterial often has that sudden onset severe pain, maybe the pain out of proportion, possibly a pain-free interval, then late deterioration. But imaging is really key for differentiation.
Okay, so imaging for MVT. What's recommended?
CTA is the recommended imaging modality for suspected MVT or venous mesenteric ischemia. That's recommendation 46, Class 1, Level B.
What kind of CTA protocol for MVT?
A triphasic CTA protocol, similar to AMI, but with particular attention to obtaining a good mesenteric venous phase. This typically involves a longer delay between contrast injection and image acquisition, maybe around 70 to 90 seconds, to allow optimal opacification of the portal and mesenteric veins.
What does CTA show?
It allows differentiation of arterial versus venous problems, maps the extent of the venous thrombosis, visualizes a lack of luminal enhancement or a filling defect, and can show associated signs of bowel ischemia, like bowel wall thickening, abnormal enhancement, ascites, mesenteric edema. Sometimes CT without contrast might show hyperattenuating bright material within the portal or mesenteric vein due to acute thrombus. It can also show signs related to portal hypertension in chronic cases. Figure 7 in the source likely illustrates these findings.
Was MRA an alternative?
Yes, MRI may be considered an alternative to CTA, Rec 47 Class 2B Level C, using similar rationale as for arterial disease, renal function contrast allergy.
What about ultrasound or conventional angiography?
Duplex Ultrasound, DUS, can show thrombus within the veins and assess flow patterns using Doppler. However, visualization can be limited by extensive thrombosis or overlying bowel gas. Conventional angiography, DSA, is actually less sensitive for diagnosing MVT than CTA. Findings like a prolonged venous phase are nonspecific. DSA might only be diagnostic in 50–60% of cases, Rec 48 Class 2A Level C, so CTA is really the workhorse.
Okay, another micro recap. We've shifted to mesenteric venous thrombosis, MVT, the second most common cause of mesenteric ischemia, often presenting more insidiously than arterial causes. Etiology follows Virchow's triad, often secondary to underlying issues, making screening for thrombophilia, malignancy, and inflammation important. Rex 4043. It covered acute versus chronic presentations and septic PVT. For diagnosis, CTA with a dedicated venous phase is key. Rec 46, Class 1 Level B, with MRA as an alternative. Rec 47. Now, let's move on to treatment strategies for MVT.
All right, treatment for MVT. Management has evolved, but there's still no universal agreement on the optimal strategy, largely because it's relatively rare, meaning no large RCTs exist. The reported in-hospital mortality, around 12–20%, is generally lower compared to other causes of acute mesenteric ischemia, like arterial occlusion or NOMI.
Is a team approach helpful?
Yes, a multidisciplinary team approach involving gastroenterologists, GI surgeons, vascular surgeons, interventional radiologists, and coagulation specialists is recommended and may improve outcomes.
What's the main treatment modality?
There's general agreement that the main treatment is conservative, using anticoagulation combined with supportive care.
What does supportive treatment involve?
This should be initiated immediately upon diagnosis. It includes adequate pain control, fluid and electrolyte replacement. Patients can become very volume depleted due to bowel edema and bowel rest, nil by mouth initially. Nasogastric aspiration might be needed for ileus, distension, nausea, or vomiting. Nutritional support, often parenteral initially, and blood transfusion if bleeding occurs are important.
Are antibiotics needed?
The evidence isn't strong. Antibiotics haven't been shown to improve mortality or length of stay in uncomplicated MVT, but they are often considered due to the theoretical risk of bacterial translocation across the compromised bowel wall, or if there are signs of perforation or sepsis.
Okay, let's focus on anticoagulation. You said it's the cornerstone.
Yes, anticoagulation is the cornerstone of treatment for MVT. This is recommendation 49, Class 1 Level B.
What are the goals of anticoagulation here?
The goals are primarily to prevent the thrombus from propagating further, to promote recanalization of the thrombosed veins, and importantly, to prevent recurrence of MVT or other VTE events.
How's it started?
It should be started immediately upon diagnosis, typically with parenteral anticoagulation using either low molecular weight heparin, LMWH, or unfractionated heparin, UFH. LMWH is generally preferred in non-pregnant patients. This is then usually transitioned to an oral anticoagulant, either a vitamin K antagonist, EKA, like warfarin, or one of the direct oral anticoagulants, DOACs and OACs.
Does anticoagulation actually dissolve the clot? Recanalization rates?
Anticoagulation doesn't actively dissolve the clot, but it prevents extension and allows the body's natural fibrinolytic system to work. The rate of recanalization reported in studies with anticoagulation alone is quite variable, ranging from 30% to 90%.
What predicts poor recanalization?
Factors associated with poor recanalization on anticoagulants include having very extensive thrombosis initially,
Right.
PG involving both PV, SMV, and branches, and the presence of ascites. The guidelines suggest patients with these features might be the ones who could potentially benefit from more aggressive therapies beyond just anticoagulation.
Are DOACs effective for MVT?
There are no large RCTs specifically for DOACs in MVT, but the guidelines state there's no reason to believe they wouldn't be as effective as VKAs. They are increasingly used.
How long should anticoagulation continue?
This is a key question. Recommendation 50, Class 1 Level B, states treatment should continue for at least 3 to 6 months, or indefinitely if underlying persistent prothrombotic risk factors are identified.
So potentially lifelong.
Yes. Lifelong anticoagulation is generally recommended for patients with a proven significant underlying thrombophilia, like APLS, maybe homozygous factor V Leiden, multiple defects, to those who have had recurrent venous thrombosis, MVT or other VTE, or 3, situations where progression or recurrence of thrombosis would likely have severe clinical consequences, for example, extensive initial MVT. The optimal duration is still debated, especially for provoked MVT, where the trigger is transient.
What about the bleeding risk with long-term anticoagulation?
Bleeding is a major concern, especially gastrointestinal bleeding. One cohort cited reported a bleeding rate of 6.9 per 100 patient years, mostly GI bleeding. Gastrointestinal varices from portal hypertension and warfarin therapy were independently associated with bleeding risk. Patients with underlying cirrhosis have the highest rates of both thrombotic events and major bleeding. Patients whose MVT was related to a transient risk factor had the lowest rates.
Has anticoagulation caused variceal bleeding?
It's complex. The presence and size of varices seem associated with recurrent bleeding independently of whether the patient is on anticoagulant therapy or not. The guidelines specifically state that anticoagulant drugs in patients with chronic MVT who have variceal bleeding or hypersplenism without signs of recent occlusion should not be considered. The risk likely outweighs the benefit in that specific scenario.
Any alternatives to oral anticoagulants?
For secondary prevention, LMWH for 3 to 6 months might be an alternative to VK-DOACs in some cases. Imaging follow-up might help determine the duration of therapy unless a decision for lifelong treatment has already been made based on risk factors.
Okay, what about more invasive treatments? Endovascular options for MVT.
These are used in a small proportion of patients, maybe around 5%, typically those who deteriorate clinically during medical treatment with anticoagulation alone, or those with persisting severe symptoms, worsening pain despite anticoagulation, early signs of peritonitis, but who might be poor surgical candidates.
That's kind of procedures.
Various techniques have been described in case reports and small series. These include placing a TIPS, transjugular intrahepatic portosystemic shunt, often combined with mechanical aspiration thrombectomy, direct catheter-directed thrombolysis, infusing clot-busting drugs directly into the thrombus, thrombolysis combined with angioplasty, percutaneous transhepatic thrombectomy or thrombolysis, or even thrombolysis delivered via a catheter placed in the SMA to reach the venous side via the capillaries. Figure 6 in the source provides a flowchart outlining these pathways.
How effective are these?
Rapid thrombus removal or dissolution is possible. TPS might help by creating a low-pressure outflow, potentially enhancing thrombolysis. Success rates in acute or chronic MVT have been reported. Systemic thrombolysis is rarely used due to high bleeding risk. Catheter-directed thrombolysis allows lower doses and might be more effective with less bleeding compared to systemic. Direct venous access, transjugular or transhepatic, allows even lower doses and potentially faster resolution. Some small studies report favorable survival with endovascular therapy plus anticoagulation compared to anticoagulation alone in selected patients. Mechanical thrombectomy might remove clot quickly, but carries a risk of intimal trauma promoting rethrombosis.
So are they recommended?
Here's the key point from the guidelines. At present, there is no evidence from robust studies to support recommendations for thrombolysis or other endovascular therapies for acute MVT. The data is just too limited. Case report, small series. They highlight the need for studies, perhaps registries, to assess if these treatments are truly indicated, particularly for patients with extensive thrombosis who fail to improve on anticoagulation alone.
When is open surgery indicated for MVT?
Open surgery is generally reserved for patients with persisting or worsening symptoms despite medical endovascular therapy, and definitely for those who develop frank bowel perforation or clear signs of peritonitis.
What's the goal of surgery?
The main aim is to remove any irreversibly ischemic or infarcted bowel while conserving as much viable bowel as possible. The difficulty lies in choosing when to operate and deciding what bowel to resect. There are no clear-cut criteria. Clinical judgment is critical. Assessing bowel viability can be very difficult due to the significant edema often present in venous ischemia.
Second looks again.
Yes, liberal use of second and third look laparotomies may be needed to ensure all non-viable bowel is removed and viable bowel is preserved. Primary anastomosis is often difficult and risky due to the bowel wall edema and is preferably postponed until a later laparotomy when the bowel is healthier. The damage control approach, immediate lap, resect obvious infarct, no attempted continuity, temporary closure, planned repeat lap, is often implied. For very high-risk patients, immediate resection of clearly infarcted bowel only without attempting revascularization, which isn't usually possible surgically for MVT anyway, might be the only option.
And outcomes for MVT overall.
As mentioned, recanalization rates with anticoagulation alone vary widely, 30 to 90%. Mortality with medical treatment is around 12–20%. Endovascular therapy plus anticoagulation has reported success 90% and mortality around 12% in one study, but likely in selected patients. Recurrence rate of MVT or other VTE is significant, maybe around 30% over 5 years, depending on underlying risk factors. Bleeding remains a major concern with treatment.
That's a very thorough overview of MVT. Recap. MVT often presents more gradually than arterial issues. Etiology links to Virchow's triad, needing workup for underlying causes, Rex 40-43. CTA with venous phase is key for diagnosis, Rec 46. Anticoagulation is the cornerstone, Rec 49, often long-term, Rec 50, balancing thrombosis versus bleeding risk. Endovascular options exist for failure of anticoagulation but lack strong evidence. Surgery is for peritonitis or clinical worsening. Let's finish with mesenteric arterial aneurysms and isolated mesenteric artery dissections, starting with aneurysms.
Okay, mesenteric arterial aneurysms. True aneurysms involving all issues of the vessel wall are rare, with that prevalence of 0.12%. They are usually silent but carry a risk of rupture, which can be fatal. Pain might occur at rupture or signal impending rupture. Thrombosis or embolization from the aneurysm causing ischemia or organ infarction is rare.
What's cytoaneurysm again?
False aneurysms or pseudoaneurysms result from a breach in the arterial wall, with the hematoma contained only by surrounding tissues or adventitia. They are more common than true aneurysms and often result from acute or chronic inflammation infection, commonly pancreatitis, trauma, including iatrogenic injury during hepatobiliary procedures, or sometimes are idiopathic.
Do they behave differently?
Yes, pseudoaneurysms generally have a higher rupture risk than true aneurysms of similar size and should usually be treated promptly. Rec 56, Class 2B, Level C. One series found 94% of bleeding visceral aneurysms were pseudoaneurysms.
Where do these aneurysms occur most often?
The splenic artery, SA, is the most common location for true aneurysms, about 60%, followed by the hepatic artery, HA, about 20%, but virtually all mesenteric vessels can be involved. Post-stenotic dilatation, especially of the CA and MALS, can also occur. It's also important to know that concomitant aneurysms elsewhere, other visceral arteries, aorta, iliac, even intracranial, are found in up to 1/3 of patients. Organ transplant recipients might also be at increased risk.
How are they usually diagnosed?
Most commonly, mesenteric aneurysms are incidental findings on abdominal imaging done for other reasons, like ultrasound, CT. CTA allows for accurate diagnosis, characterization of the anatomy, size, location, neck, relation to branches, and is crucial for planning any intervention, Rec 51, Class 1 Level C. MRA may be considered an alternative, Rec 52, Class 2B Level C. DSA is usually reserved for treatment, embolization, stenting, or if C-TAMR are inconclusive.
When is intervention necessary? We mentioned pseudoaneurysms should be treated promptly. What about true aneurysms?
For asymptomatic true aneurysms, the decision is usually based on size and location. Recommendation 53 suggests intervention should be considered at a diameter 25 mm, Class 2A Level C. Rupture risk increases significantly above this size threshold for many locations.
What about smaller asymptomatic true aneurysms?
For asymptomatic true aneurysms with a diameter 25 mm, recommendation 54 suggests imaging surveillance at 2–3-year intervals may be considered, Class 2B Level C. However, data on the natural history and optimal surveillance interval for small aneurysms is limited and prospective data is needed.
Okay, so if treatment is decided, what are the options? Open versus endovascular again.
Yes. Once intervention is deemed necessary, meticulous imaging is required to plan the strategy. Treatment might involve primary occlusion of the affected vessel segment containing the aneurysm, using coils, plugs, or surgical ligation, or reconstruction to preserve flow. Stent graft, surgical bypass interposition graft.
How is the choice made?
Selection depends on patient characteristics, surgical risk, aneurysm anatomy, location, neck suitability for endo, local expertise, and patient-physician preference. There are no RCTs or large prospective studies comparing open versus endovascular repair for mesenteric aneurysms due to their rarity. Evidence is mostly from retrospective series.
What does the evidence suggest about outcomes?
Retrospective studies show that elective repair, whether open, laparoscopic, or endovascular, generally has very low mortality, fewer 3%. However, perioperative morbidity tends to be higher with open repair. This is somewhat offset by a small but relevant early failure rate, for example, endoleak, and late reperfusion risk with endovascular techniques, sometimes needing secondary interventions. Open repair offers the advantage of potentially more complete aneurysm exclusion and minimal compromise of collateral vessels. In the setting of rupture, the benefit of endovascular treatment might be greater due to the higher physiological insult of emergency open surgery.
What are the specific techniques?
Open or laparoscopic techniques include aneurysm resection with end-to-end anastomosis, reimplantation onto another vessel, graft interposition, simple ligation if collaterals are adequate, or sometimes organ resection, like splenectomy for complex splenic artery aneurysms. Endovascular techniques include placing a covered stent across the aneurysm neck to exclude it, embolization of the aneurysm sac itself using coils or glue, or sometimes including both the inflow and outflow vessels around the aneurysm trapping.
Which endovascular technique is most common?
Coil embolization is most commonly used due to its wide applicability and generally high technical success rates. Glue embolization is also used, but can be technically challenging with a potential risk of non-target embolization. Flow-diverting stents are being explored for complex aneurysms, but data is limited. Percutaneous thrombin injection has shown high recurrence rates.
Preserve flow if possible.
Yes. Recommendation 57, Class 1 Level C, states that arterial reconstruction, preserving flow, is recommended over simple vessel occlusion whenever technically possible in a patient who is not at high surgical risk. And Recommendation 58, Class 2A Level C, suggests endovascular repair should be considered if anatomically suitable, given its lower perioperative morbidity compared to open surgery.
Okay, quick micro recap on aneurysms. True or rare, pseudo more common, and higher rupture risk. Diagnosis via CTA, Rec 51. Treat pseudo promptly, Rec 56. Consider treating asymptomatic true aneurysms equals 25 mm, Rec 53. Survey smaller ones, Rec 54. Open versus endo depends on case. Rec 57, 58. Endo less morbid but may need reintervention. Coils common. Finally, let's look at follow-up and then isolated arterial dissections.
Right. Follow-up after treatment for mesenteric aneurysms, it really depends on the underlying disease, true versus pseudo, and the method of treatment. After successful open surgical repair of a true aneurysm, routine imaging surveillance isn't usually considered necessary unless there's an underlying condition like vasculitis that might cause new problems.
What about after endovascular repair?
After endovascular treatment, especially for true aneurysms, for example with coils or stent grafts, follow-up imaging is generally advised. Early imaging, CTA or MRA might be better if coils cause artifact on CT, is needed to confirm successful occlusion or exclusion of the aneurysm sac. Repeated imaging is advised later because of the risk of late recurrence or endoleak. Rec 59, Class 2B Level C. The guidelines suggest imaging at 3-year intervals may be considered to detect late failures, but acknowledge this isn't strongly data supported.
And after pseudoaneurysm treatment.
If a pseudoaneurysm is effectively treated with inflow and outflow embolization, trapping, routine follow-up imaging may not be needed as the recurrence risk is considered small. However, if the underlying cause of the pseudoaneurysm persists, like ongoing pancreatitis, repeated imaging is recommended due to a high risk of recurrence. Pseudoaneurysms treated only by thrombin injection also have a higher recurrence risk, so repeated imaging is advised there too. The guidelines note they couldn't find data on the natural course of observed pseudoaneurysms, i.e. not treated.
Okay, last major topic. Isolated dissections of the mesenteric arteries.
IMAD.
Yes, IMAD. This is considered a rare condition, but it's being diagnosed more frequently now due to the widespread use of high-quality CTA. They can be found incidentally or in patients presenting with abdominal pain or suspected ischemia. The evidence base comes almost entirely from case series.
Who gets IMAD? What are the patient characteristics?
Most of the reported experience comes from Asian countries, China, Korea, Japan, but it's seen worldwide. The underlying etiology is largely unknown. It seems to be associated with hypertension, present in about 39% of one analysis. But interestingly, diabetes prevalence is low, around 8%. Patients are relatively young, mean age around 55 years, and there's a strong male preponderance, about 85%. Table 6 summarizes these risk factors. Smoking, 38%, and dyslipidemia, 20%, are also noted.
How is IMAD diagnosed? Most symptomatic patients present with abdominal pain, around 91%. However, a significant proportion, about 26% in the analysis, were asymptomatic, found incidentally. There are no specific lab tests. Diagnosis is established by CTA, which shows the dissection flap, false lumen, potential thrombosis, or aneurysm formation.
Are there classification systems?
Yes, two main classification systems based on CTI findings are described, illustrated in figures 8 and 9. The Sakamoto classification, types 1-4, and the Yon classification, types 1, 3, describe features like the presence and location of entry tiers, whether the false lumen is patent or thrombosed, the status of the true lumen, compressed or not, and the presence of ulcer-like projections. However, the guidelines importantly state that neither the Sakamoto nor the Young classification has been shown to reliably predict the clinical course of the dissection.
So, how are these patients treated?
The main aim of treatment is to prevent intestinal ischemia or arterial rupture. Although most symptomatic patients present with acute abdominal pain, the key finding from the case series is that the majority can be treated without intervention.
Conservatively.
Yes. In the data set analyzed for the guidelines, 75% of patients were managed conservatively. This typically involves food withdrawal, bowel rest, intravenous hydration, analgesia, blood pressure control, and often some form of anticoagulation or antiplatelet therapy, though the type and duration varied widely in the studies, and no specific recommendation could be given regarding the optimal medical regimen.
What about intervention?
About 20% of patients in the dataset underwent endovascular intervention, which was predominantly stenting of the dissected CA or SMA. Only 6% required open surgical revascularization. Bowel resection was needed in only 1.3% of cases, and in-hospital mortality was very low at 0.6%.
Does conservative management ever fail?
Yes. Failure of medical treatment, meaning worsening symptoms or development of ischemia needing intervention, occurred in about 16% of patients with symptomatic SMA dissection and was higher, 45%, in those with combined CA and SMA dissection. Predictors suggested for failure of medical treatment include developing signs of peritonitis or bowel infarction, having the dissection extend into branch points, CA dissection specifically, the presence of aneurysmal dilatation associated with the dissection, and possibly younger age. Early intervention should be considered for these higher-risk patients.
So what are the specific recommendations for IMAD treatment?
Given the generally benign course for many, the recommendations lean conservative initially. Recommendation 61, Class 1 Level C. For asymptomatic IMAD, conservative management is recommended. Recommendation 62, Class 1 Level C. For symptomatic IMAD without signs of peritonitis or bowel infarction, conservative management is also recommended initially.
When is intervention recommended?
Recommendation 63, Class 1 Level C. If conservative therapy fails, persistent worsening symptoms, or if there are signs of bowel ischemia, then revascularization is recommended. Endovascular therapy is preferred over open surgery, if technically feasible. If endovascular fails or isn't feasible, then open surgery is indicated.
What about follow-up after IMAD?
The guidelines highlight the need for studies with systematic and sufficiently long follow-up to really determine the natural course after IMAD. Based on existing midterm data, median follow-up around 21 months, the need for late reintervention seems uncommon. However, Recommendation 64, Class 2A Level C, suggests that follow-up with imaging should be considered after IMAD to detect potential late complications like aneurysm formation, occlusion, or stenosis of the affected artery. CTA or MRA can be used for this follow-up.
Okay, that brings us to the end of the specific conditions. To recap, IMAD, rare, seen more with CTA, affects younger males, often with hypertension. Diagnosis by CTA, classifications exist but don't predict outcome. Importantly, most can be managed conservatively initially, Rec 61, 62. Intervention, endo preferred, Rec 63, is for failure or ischemia signs. Outcomes generally good. Follow-up imaging should be considered, Rec 64. Finally, Section 8 briefly touches on future research needs identified during the guideline process.
Yes, and a key takeaway they emphasize is that for many of these conditions, the overall level of evidence supporting the recommendations is low. The low prevalence makes performing large RCTs very difficult. Therefore, much of the necessary information will likely have to come from well-designed observational studies or registries in the future.
What specific areas did they highlight?
For chronic mesenteric ischemia, There's a need to improve diagnosis specifically, developing better methods to select patients who will truly benefit from intervention, perhaps by disseminating and evaluating functional tests like exercise tonometry in prospective multicenter studies, or exploring newer techniques like portal vein lactate measurement or precise blood flow quantification with MRA-CTA. Multicenter collaboration is deemed essential.
For venous mesenteric ischemia,
For MVT, they note that thrombolysis appears promising in case series, but interpreting these results is difficult due to patient selection bias. They strongly advocate for sharing data from many centers, potentially through a registry like the VascuNet collaboration between ESVS and the SVS Vascular Quality Initiative, given the low prevalence.
mesenteric artery aneurysms.
Research priorities include better defining risk factors for rupture, understanding the role of screening in specific high-risk populations like those with FMD or connective tissue disease, getting prospective data on the rupture risk of small true aneurysms, and clarifying risk factors for expansion or rupture of pseudoaneurysms. They also suggest a prospective registry of patients managed without operative intervention is warranted for small true aneurysms, given the risk of overtreatment with increased imaging detection.
And for isolated dissections.
For IMAD, the role of endovascular treatment versus conservative management needs further clarification, as does the optimal duration and frequency of follow-up examinations. Rigorous prospective cohort studies, likely requiring multi-center collaboration, especially in Europe where it seems less common than reported in Asia, are needed.
Well, we have certainly navigated a complex landscape today, covering the key facets of mesenteric arterial and venous diseases as outlined by the 2017 ESVS guidelines.
Absolutely. From those acute emergencies like arterial and venous thrombosis to the chronic challenges of ischemia and the nuances of aneurysms and dissections, we've really seen how these guidelines attempt to blend the available evidence, even when limited, with expert consensus to guide clinical management.
We've underscored the critical role of timely and accurate imaging, especially CTA, the multidisciplinary approach that's often required, and that constant balancing act between open and endovascular interventions based on individual patient factors, the specific anatomy, and importantly, those evidence grades we discussed, remembering Class 1 is should, Class 2A should be considered, Class 2B may be considered, and Class 3 should not.
Hopefully this deep dive has equipped you, our listeners, with a really detailed understanding drawn directly from this leading expert source to help inform your clinical decision-making and ultimately enhance your ability to care for patients presenting with these often very challenging conditions. We've tried to pull out the specific recommendations, discuss the evidence levels underpinning them, and highlight the clinical pearls and controversies based on the source material itself.
And as the guideline authors themselves were careful to point out, this field is definitely evolving, and the evidence base still has significant gaps. Collaborative research, development of better functional tests, and dedicated registries seem to be the crucial next steps identified to refine future recommendations.
Which leads to a final thought, perhaps. As our imaging technology becomes ever more sophisticated, we're almost certainly going to diagnose more asymptomatic or incidentally found mesenteric vascular lesions, whether that's small venous thrombi, smaller aneurysms, or these incidental dissections. The question is, how will our understanding of the natural history of these incidental findings, and crucially, the balance of risk between intervention versus observation, continue to evolve and shape our clinical practice in the years ahead?
A profound question indeed for anyone managing these patients. We hope this comprehensive deep dive has been valuable for your practice. Type continue for further detail.